to begin with, Dr. Mikhael, Mayo is one of the very first to actually publish a roadmap for newly diagnosed patients and relapsed patients based on a risk-adaptive approach to treatment, or MSMART is what you call it. And I noticed in many of your publications, you have been an integral part of putting that together. And I can tell you that I believe that this is to the world's myeloma patient community where an organization has laid out their expertise in such an understanding way to help everybody who avails themselves of this information. And it's based on testing to determine what's the best consensus approach to treatment. And if you might be able to tell us why this testing is important, what tests are important, and the frequency of those tests for a newly diagnosed patients, high and low risk, relapsed refractory patients, and also non-secretors, which is kind of a difficult one, and any other subset that you might find.
Well, thank you very much. It's a genuine pleasure to be part of this outstanding session, and I'm grateful for the opportunity to do so. I think the best way to approach this is initially to lay a background that, as you mentioned and Priya mentioned in her opening remarks, multiple myeloma, I like to say sometimes is appropriately called multiple because it's not a single disease, as it were, meaning every patient is quite unique. Every disease has a spectrum, but I would argue that multiple myeloma has one of the widest spectrums of any cancer that we have. And so it really emphasizes the point of appropriate diagnosis. And when we mean appropriate diagnosis, we both mean a timely one and an accurate one. And so when patients are initially diagnosed with multiple myeloma, it's critical that we understand the full nature of their myeloma. And the reason for that and the rationale behind the MSMART guidelines was to be very practical, but to also identify that there are patients who have what we might call higher risk myeloma and patients who have lower risk myeloma, meaning patients have myeloma that seems to grow much more quickly and that grows much more slowly. And as a result, we would want to intervene differently in a patient who has a much more rapidly growing disease than that who has a slower growing disease. And to help make that distinction, we've come to realize that it's not just, if you will, the volume of the disease, but the pace of the disease, meaning it's not just the size of the tumor, as it were, but the underpinnings of the tumor. And the simplest way I would lay out what tests need to be done is I'd put them in categories. Category number 1, we need appropriate blood tests. Category number 2, we need radiological tests. And category number 3, we need specialized tests out of the bone marrow. So for the basic blood tests, and I know we don't want to spend too much time on the very simple basics here, but people need basic blood counts, the 3 key cells that get generated from one's blood, what I jokingly sometimes call the white, red, and rosé. We need the white cells, the red cells, and the rosé cells, or the platelets. Secondly, within the blood work, we need the chemistry. We need to understand someone's kidney function, their calcium level. These are the blood tests that define the damage that unfortunately myeloma can cause to the kidney and to other organs in the body. And then the third aspect of the blood tests are the ones that are often not done particularly well, and I would want our patients and others listening to make sure they capture this carefully, are the myeloma-specific blood tests. So we know that myeloma is a disease of the plasma cell. The plasma cell is a cell that makes normal proteins in our blood that would normally fight off infections. But unfortunately, when the plasma cells become abnormal, they make abnormal proteins, and we measure those through various tests. And the critical 2 tests are what's called the serum protein electrophoresis, where we measure the normal and abnormal proteins in the blood, and we can quantify the abnormal component, sometimes called the M component or the M spike, because when we do it in the lab, it looks like a little spike of protein on the plate. And that M spike becomes critical because that's the measure of the disease. It's like measuring perhaps someone's lung cancer on an X-ray. We see and we take out the ruler and say, oh, it's 10 centimeters long, and as we treat it, we see it shrink. Well, similarly with the M spike, it has to be followed. But in addition to the M spike, there is another blood test called the free light chain measurement, or the immunoglobulin light chain test. 20% of myeloma patients don't have an M spike at all, actually, or the bigger protein. Their myeloma only makes the smaller protein, what's called the light chain. And so we can measure those light chains in the blood as well. And the majority of myeloma patients will have both an M spike and a light chain. And we've come to learn that it's critical not just to measure one or the other, but to measure both. They usually move in sync, but sometimes they don't, especially with relapse later on. It can be confusing. The second category of tests were the radiological ones. I won't spend much time there, but we would generally do a basic plain X-rays, what's sometimes called a skeletal survey, as just a baseline to see if the bone is involved. But very often we might go to something more specialized, such as an MRI test, or potentially even a PET scan if we want to understand the disease a bit more, and I'll come to that in a moment when we talk about non-secretory disease. And the third major category is the bone marrow test, and this is really the foundation to the MSMART guidelines that you'd made reference to, Gary, which was that this is the home of myeloma. Myeloma grows in the bone marrow, so we measure the volume or the percentage, if you will, of those abnormal plasma cells. But it's not just measuring those bad cells in the bone marrow. Sometimes I call them the bad military or police force, because they're the ones that are supposed to protect you but are now not protecting you. But we go down a bit further to do what's called cytogenetic testing, and those cytogenetics are absolutely critical. We usually do those through a process called FISH, or fluorescent in situ hybridization. So I tell patients, make sure your doctor knows how to go FISH, because we want to be able to get those FISH tests, because what those do is they highlight key genes that we know are affected in myeloma, those genes that will distinguish a high-risk patient from an intermediate-risk patient to a low-risk patient. And the presence or absence of certain genes, and for time's sake we won't go through them all, people can look at these in detail at our msmart.org website, but here we identify certain key ones. For example, what's called the P53 deletion, or sometimes called 17p deletion. When someone's missing a piece of chromosome 17, that puts them in the high-risk category, because that part of the gene that's missing is part of the gene that normally keeps cells in check. And so if the supervisor is away, then there can be chaos, and the disease can grow uncontrollably. And those individuals will need to have a different kind of therapy than those who, by contrast, may have extra copies of certain chromosomes, something we call hyperdiploidy, which puts people in the low-risk category. And our suggestion is that all newly diagnosed myeloma patients need the blood test, need the X-ray, need the bone marrow with the FISH analysis, because that'll help us determine which category they land in and how they're initially treated. At relapse, or when the disease, unfortunately, as we know, myeloma currently is not curable, but we're getting closer to that goal, we would want those tests repeated, and in particular the FISH testing repeated, because the genetics of those plasma cells can change with time, and someone can unfortunately move from a standard or intermediate risk category into a high risk category. So patients should, as they're being treated, their blood work is checked on a regular basis. Their disease starts to grow again, they should absolutely have a repeat bone marrow where the FISH testing is done. The final category you asked me about was the non-secretory patients. There is a small proportion of patients, somewhere around 2 to 3% of myeloma patients, where these bad plasma cells in the bone marrow, they're bad and they're there, but they don't actually release the bad protein into the blood, and so we can't follow them with a serum protein electrophoresis. We can't follow them with the light chain measurement. Those patients we tend to follow with PET scans, or in some cases an MRI. The PET scan is more an accurate measure of the disease, because we can often see the disease light up, as it were, on the PET scan. And we don't do those monthly like we would with most of the blood work, of course, because that would be a bit excessive. But we tend to do them at either 4 or 6 month intervals, depending on what treatment they've received, to be able to follow their disease. And we know that it's a little bit more challenging. Sometimes we're able to capture their disease in their urine, but more often than not, if they're a true non-secretor, we have to follow them through a PET scan. I hope that answers your question.
Yes, it does, Doctor. Thank you very much. One thing you didn't mention, and it's something that we see quite a bit in the literature coming up, is a thing called gene expression profiling, and that's included in the U.S. National Comprehensive Cancer Network and the International Myeloma Working Group guidelines. And this is a newer measurement technique. And is it important, and what do you see for the future use of this measure?
Yeah, it's a great question. That the myeloma community is still a little bit divided over this. The concept here, as opposed to the FISH testing that I described, where we go down and look at 1 or 2 specific or several specific genes, this looks at almost like what we might call a genetic signature. It looks like at a pattern of genes. And part of the challenge is that there are different tests for gene expression profiling, and some measure 70 genes or 80 genes or 90 genes, but they tend to look at the same kind of concept of saying, does someone have a high-risk signature or a lower-risk signature? One of the reasons why I didn't include it right away is, as I say, there's still a little bit of a difference of opinion as to how valuable it is and what exactly we do with it. But it is, I think, in the near future going to become more standard practice. As you mentioned, the NCCN and our International Myeloma Working Group have recommended that it be a consideration if it's available to people, because it does a similar kind of thing to the FISH testing, but it looks at a broader group of genes. And again, it's into a category of higher risk or lower risk disease that might influence the specific therapy. Now, it hasn't been validated as much as some of the FISH testing in terms of specific treatments for specific genetic abnormalities, but those kinds of things we're doing now. So I wouldn't want our listeners to think, oh no, I haven't had gene expression profiling, I'm really missing out. But I would keep an ear to the ground for it, because before too long, it'll probably be a more important tool in our toolbox.
Well, thank you, Doctor. I appreciate that. That description. Dr. Morgan calls the delay in diagnosis. He's from the UAMS, but previously studied or worked in England. The delay diagnosis of more than 6 months from first symptoms to diagnosis is a scandal. And what he means by that is that the general practitioner doesn't seem to identify myeloma until it ends up with end organ damage. And what can general practitioners do to find it earlier before it does reach that critical function? For me, for example, I don't have a whole kidney anymore, and for other people, they've got bone destruction, and I know somebody else who had a problem with a stroke. And so, once you get to that point, it's something that you live with the rest of your life. It'd be nice to think that there'd be something that could be done, some tests that would help us find this earlier in the.
Well, you do highlight a very challenging question and a very important one. And frankly, I think talks like this help because it's really a multifold answer. I would suggest that, number one, it's just greater awareness of myeloma. And I think now that we have better treatments for myeloma and patients are living with myeloma, there's a greater general awareness. The second thing is having accurate testing that can guide our general practitioners or general internists. Many of these individuals, they work so hard in practice, and they can see, for example, 100 patients with back pain in the next several years, and not one of them will have myeloma, but then the 101st does. So how do you keep myeloma on the radar screen for all the different ways that myeloma can present, with back pain or kidney trouble or low hemoglobins. And I do a lot of talks for general practitioners and general internists to say, look, myeloma might not be the top of your differential diagnosis, but when key things are present, please keep it in the list of your thinking. So anyone who's got a low hemoglobin or anemia, and especially if they're over the age of 50 or 60, because that's more common in myeloma, it should at least be a consideration, and starting with that simple serum protein electrophoresis or light chain test can be helpful. If someone has kidney damage that's not clearly explained by other means, if someone has thinning of the bones or a fracture that doesn't fit with their age or the trauma that they may have experienced, those tend to be the most important trigger points. Or if when blood work is done, there's evidence of an abnormal or excessive protein in the blood. So I think part of it is awareness in general of myeloma, of equipping and training our internists and general practitioners to understand that at those 3 or 4 trigger points, they have to start at least considering the diagnosis. And then, of course, when abnormalities are detected, to expedite a more detailed investigation, usually by a hematologist or a hematologist-oncologist. Because I agree with Dr. Morgan, it's tragic when we see patients, and I saw a patient today who, for 8 months, was shuttled around to different places trying to figure out why he was as sick as he was, until the penny dropped and someone said, oh, maybe this person has myeloma, and sadly he does. So it's not a simple answer, but I think raising awareness and understanding key areas to watch for with the better testing that we have now, I think is going to help at least alleviate part of that problem.